Hello and welcome to the Spinal Cord Injury Forum. My name is Heather Barnett. I am a spinal cord injury physician with the Department of Rehab Medicine at the University of Washington and the new director of the Northwest Spinal Cord Injury System. Tonight we are very pleased to welcome Dr. Shawn Song. Dr. Song is a spinal cord injury attending physician and assistant professor at the VA Puget Sound Healthcare System and the University of Washington. Tonight, Dr. Song will be presenting on spinal cord injury and autonomic dysfunction. Welcome, Dr. Song. Thank you for being here.
Thanks. Thanks very much for having me. Very happy to be here tonight and to chat about the autonomic nervous system and autonomic dysfunction after spinal cord injury. All right, let's get started here. So the topics that I'd like to cover tonight, I want to go over an overview of the autonomic nervous system, and then like to talk about some specific examples of autonomic dysfunction after spinal cord injury. Autonomic dysreflexia, which is kind of the classic example of autonomic dysfunction after SCI, orthostatic hypotension, and temperature dysregulation. And then we'll wrap up by talking about a few new interesting areas of research, including ambulatory blood pressure monitoring, cognitive impairment after spinal cord injury, and response to widespread infection or sepsis. So I think it's very important that for this talk and this presentation, we start off by trying to get a basic understanding of the autonomic nervous system. It's really central to the topics that we'll talk about, and I think it's if we put a little bit of time in up front, it'll make the rest of the talk a little bit more understandable and hopefully enjoyable. So the autonomic nervous system is actually made up of three components: the sympathetic nervous system, the parasympathetic nervous system, and the enteric nervous system. We're not going to really spend much time talking about the enteric nervous system, so we'll really focus on the sympathetic and parasympathetic nervous systems. Most organs in the body are influenced by both components of the autonomic nervous system. There are some important exceptions which we'll talk a little bit more about tonight. Those exceptions include most of the peripheral blood vessels, the sweat glands, and the muscles that are involved in creating goosebumps. Those are only receive sympathetic innervation. And then the whole autonomic nervous system is controlled by the brain, although there is some reflex activity of the autonomic nervous system. The brain really has overarching control of the autonomic nervous system. So in terms of function, the sympathetic and parasympathetic nervous systems have opposing functions. The sympathetic nervous system helps the body respond to dangerous or stressful situations, while the is hence kind of referred to as the fight or flight response. And the parasympathetic nervous system is responsible for the rest and digest response, which kind of helps you relax after a dangerous or stressful situation. So to talk about the specific activities or specific functions of the sympathetic nervous system, let's imagine that you're kind of in the jungle and encounter a large, scary-looking tiger. That will certainly set off your sympathetic nervous system. So that will get your body to fight or flight, run away. I think probably most of us would be running, but the body, the sympathetic nervous system, it dilates the pupils so that it helps individuals see in low light environments. It kind of readies the cardiopulmonary system to be able to exert itself, so it will increase the heart rate, dilate the airways. It will cause the liver to release glucose, which is a very quick energy source for the body to use. And it will also stop bodily functions that are really not needed during this fight or flight response. So It will try to shut down digestion. It will inhibit saliva production, inhibit digestion in the stomach, inhibit movement of the intestines, and it will also relax the bladder so you're not feeling the urge to urinate, and it will decrease flow to the reproductive organs because that is generally a function that is not thought about or needed during the fight or flight response. And on the other hand, let's say you safely escaped from this tiger and now kind of relaxing on a beach. So the parasympathetic activity will ready the body to rest and digest. So it will constrict the pupils, because generally you won't need to see in low light situations. Then it will produce saliva. It will help the stomach digest as well as the intestines. It will cause constriction of the bladder to allow one to empty your bladder during this kind of rest and digest period. And it will also increase blood flow to the reproductive organs, because generally reproduction occurs during these kind of rest periods. And then in terms of just the anatomy of the autonomic nervous system, we won't get into the nitty-gritty of the anatomy, but I do think it's important to know kind of in general where the parasympathetic and sympathetic nervous systems live in the spinal cord. So the parasympathetic nervous system has its origins in the brain stem and the very bottom of the spinal cord, called the sacral spinal cord, and it's said to have craniosacral outflow. In contrast, the sympathetic nervous system, it originates in the thoracic and in the lumbar spinal cord, and is said to have thoracolumbar outflow. So, just to review, the parasympathetic nervous system comes from the very top and the very bottom of the spinal cord, whereas the sympathetic nervous system comes from the middle of the spinal cord. Okay, and that's going to be important when we talk about different signs and symptoms we can see during autonomic dysreflexia. So now we'll just spend a few minutes talking about a couple of specific organ systems and how they get influenced, or where the influence of the sympathetic and parasympathetic nervous systems come from. So when thinking about the cardiovascular system, you have sympathetic outflow that's coming from, as we mentioned, the thoracic cord, specifically kind of the top of the thoracic cord. T1 to T5 is thought to have sympathetic outflow to the heart, and as well as the vessels in the upper body. And activation of the sympathetic nervous system will cause an increase in heart rate, will cause constriction of the vessels. And then the kind of middle and lower part of the thoracic cord and the top of the lumbar spinal cord supply the sympathetic signals to the vessels in the lower half of the body, and in particular the splanchnic vascular bed, which is actually fairly important, and we'll talk about that in the next slide. And again, the sympathetic activation causes vasoconstriction or constriction of these vessels. The heart also receives parasympathetic signals from the brainstem and through the vagus nerve, and when the parasympathetic nervous system is activated, you see a decrease in heart rate and a decrease in the contractility, or the kind of squeezing function of the heart. Okay. And moving on to the splanchnic vascular bed. This vascular bed has particular importance in autonomic dysreflexia, which is why we'll spend just a little bit of time talking about this. So the splanchnic vascular bed refers to the blood vessels that supply the liver, the stomach, the spleen, the pancreas, and the small and large intestines. And this is your body's largest reserve of blood. It can hold up to 25% of your blood volume when the vessels are dilated. And of course, it's much less than that when the vessels constrict. But because this is such a large vascular bed, when you get constriction of this vascular bed, that causes the body to have high blood pressure. So this vascular bed is very influential in determining what somebody's blood pressure is. And as we kind of mentioned, the sympathetic signals to this vascular bed, they come from the thoracic cord. In particular, it's thought to come from around T5 to T9. You may see some other sources cite as low as L2, but I think the important thing to remember is kind of the mid to lower part of the thoracic cord is what is thought to supply the sympathetic signals to the vascular bed, this splanchnic vascular bed. And as I mentioned before, when the sympathetic nervous system is activated, that will cause constriction of these vessels. And it's important to note also that these vessels and most of the vessels in the body are not influenced by the parasympathetic nervous system. So how they change from being from a constricted state to a dilated state is just based on the sympathetic nervous system. When the sympathetic nervous system is really turned on, the vessels will be constricted. If the sympathetic system is inhibited or turned off, then the vessels will dilate. Okay? And then we'll talk about sweat glands. So again, this is another example of kind of part of the body that receives only sympathetic signals. From T1 to T4 is thought to supply the sympathetic signals to the sweat glands in the face. And when the sympathetic nervous system is activated, that causes sweating, whereas the sweat glands in the rest of the body thought to be to receive their sympathetic signals from T1 to L2. And again, as I mentioned, the sweat glands do not receive any parasympathetic signals. I should also mention, I don't have a separate slide for this, but the erector pili muscles, which are the muscles that cause goose flesh or goosebumps, they also have similar innervation as the sweat glands, and they also do not receive any signals from the parasympathetic nervous system. So these pictures here on the left are from an interesting article from 2020. And so what they did here, they put a substance, they spread a substance on the body of patients with tetraplegia and patients with paraplegia, and this substance reacts and turns purple when it comes into contact with sweat. And so they wanted to see if the level of sweating corresponded to your level of injury. So what they found is basically what you would, I think, expect from a theoretical standpoint. So the top picture represents an individual with, I believe, complete tetraplegia. And so in these individuals, they are not often able to sweat in hot environments. So right now, this person is sitting in a very, very warm room that's being turned up to, I think, as high as 40 degrees Celsius, and you can see by the white powder that they are not sweating. And then the bottom picture here is somebody with paraplegia, and they have a neurologic level of injury T8, and I believe this individual is also complete injury. And so you can see here that they're sweating above the T8 dermatome and not so much below the T8 dermatome. And so a good example of how your level of injury affects where you can sweat. Okay. And then the last part of the body that we'll talk about this specifically are the eyes. So the eyes receive both sympathetic and parasympathetic signals. The upper thoracic cord supplies the sympathetic signals to the eye, and as we mentioned in one of the earlier slides, it causes dilation of the pupils to allow more light into the eye, whereas the parasympathetic signals come from the brainstem, and activation of the parasympathetic nervous system will cause constriction of the pupils. Okay, so with that kind of brief overview and anatomy review, we'll dive into specific examples of autonomic dysfunction after spinal cord injury. So there's a whole list of examples of autonomic dysfunction. This is by no means a complete list, and we're going to only really talk about the top three. So we'll spend some time talking about autonomic dysreflexia, orthostatic hypotension, and temperature dysregulation. We'll also, at the end, talk a little bit about cognitive impairment, which is thought to be related to possibly autonomic dysreflexia and orthostatic hypotension. But the list of examples of autonomic dysfunction is quite long and includes things like having a blunted heart rate in response to exercise or in response to fever. Neurogenic bowel and bladder is tied to autonomic dysfunction, as is sexual dysfunction. And there's also some thought that the immune system is also affected when there is autonomic dysfunction. Okay. So again, as I mentioned before, autonomic dysreflexia, or AD, is generally thought to be a very classic example of autonomic dysfunction. And generally, hopefully, most patients with tetraplegia or paraplegia who are susceptible to AD will have received some education about AD during acute rehab, but often it's outside of acute rehab, it's not a topic that is talked about or taught about that frequently. So I think it's a good opportunity to just review that. So what is autonomic dysreflexia? It's defined as a sudden increase in blood pressure at least 20 millimeters of mercury above baseline. So I kind of highlighted the term baseline because sometimes that's a trickier concept than most people realize for somebody with a spinal cord injury to know their baseline blood pressure. But we'll spend a little bit of time later in the talk talking about how you can establish a baseline blood pressure. But yeah, that can be a little bit tricky sometimes. And usually AD is accompanied by a constellation of signs and symptoms, and these can include things like pounding headache, sweating, goosebumps, flushing, nasal congestion, blurred vision, and abnormal cardiac rhythms. It's rare that somebody has all of these, but usually some folks have a subset of these signs or symptoms, and people who experience AD with some frequency are generally very familiar with the signs and symptoms of that accompany their AD. Now, it's worth noting here that some folks, it's more widely recognized that some folks don't have any signs or symptoms and are still experiencing these sudden increases in blood pressure, and it's termed silent AD. And it's a little bit worrisome because then it's very difficult to know when you are having these big changes in your blood pressure. So it makes it that much more difficult to treat them if you're not even aware of them. So the people that are most at risk for AD include those people who have a neurologic level at T6 or higher. There are some rare examples of individuals who have lower levels of injury who still are susceptible, but in general that's considered fairly rare. And then your risk of AD does increase the higher your level of injury and the more complete your injury is. But I should absolutely mention that just because you are AISD, that does not mean that you are protected from AD. We have plenty of individuals who have, who are in the kind of mildest classification and still experience frequent AD. So what are the triggers for autonomic dysreflexia? This is a good one to be familiar with, just so you can have extra awareness of these events and that they might trigger AD in you. The most common triggers are overdistension of the bladder and then the bowel. And so any search for an AD trigger almost always starts with the bladder and the bowel. Other semi-common triggers include skin lacerations, wounds like pressure injuries, ingrown toenails have certainly been known to cause AD, tight clothing, and medical procedures, cathing or cystoscopy when they look in your bladder with a camera, that can often trigger AD. There's a little memory device here that can make it easier to remember some of the most common triggers of AD, and they're referred to as the 6 Bs. Some of these Bs are a little bit odd, but in any case, I think they can help you remember. So the first B stands for bladder, and that covers catheter blockages, kidney stones, or stones that are stuck in the ureter, bladder infections, or bladder spasms. The second B refers to the bowel, which covers constipation, The third B is called back passage, which refers to the rectal area and covers things like inflamed hemorrhoids or an anal fissure or a perirectal abscess. The fourth B is boils, which covers skin issues like a rash or a skin lesion or a pressure injury. The fifth B stands for bones, which covers fractures and dislocations, which I should mention, those are very possible triggers of AD, and sometimes fractures or dislocations can go initially unnoticed by a patient who doesn't have great sensation. So that's always something that should be in the back of your mind if there's not an obvious AD trigger in the bladder or the bowel. Thinking about potential occult fractures or dislocations is a good thing to keep in your mind. And then lastly, babies. So pregnancy is, from what I've been told by my wife, can be quite painful or noxious stimulus, and that is a trigger for AD, and usually that can be managed in conjunction with an obstetrician and a spinal cord injury doc working together to try to manage that. So what are the consequences of AD? Unfortunately, they can be profound. Untreated AD can certainly be life-threatening just due to sustained very, very high blood pressure. And the list of potential consequences are generally sequelae of high blood pressure. So things like a stroke, if your blood pressure is high enough that it can cause a bleed in one of the vessels in your brain, that's termed a hemorrhagic stroke, and AD has been shown to cause that in individuals. It can cause a heart attack, kidney failure, pulmonary edema, which is a term that refers to fluid in the lungs. It can cause bleeding in the retina. It can cause death from, of course, things like stroke, heart attack, pulmonary failure, pulmonary edema. Those things can all result in death if severe enough. So let's try to walk through why AD happens and what are the steps that cause it to occur. So this diagram exists in many different forms, but I think it's useful, and we can walk through the steps together here. So, AD is caused by a painful stimulus. So as I mentioned, the common causes are overdistension of the bladder or overdistension of the bowels. And when that happens, the bladder or the bowel sends these signals back to the spinal cord indicating pain. For reasons that we don't quite understand right now, after a spinal cord injury, the sympathetic reflex response can really be turned up. It can be kind of pretty massive. So when the spinal cord receives these signals indicating pain in the body, that can set off this massive outflow of sympathetic activity. And as we discussed when we were talking about the anatomy of the autonomic nervous system, we know that when the sympathetic nervous system is ramped up, that causes vasoconstriction in vessels throughout the body, and in particular the splanchnic bed. And as I briefly alluded to earlier, that constriction of those vessels in the vascular bed raises an individual's blood pressure. And so that blood pressure then is sensed by these receptors. They're called baroreceptors, and they live in the aorta and in the carotid arteries. And these receptors, they sense that high blood pressure, and they signal to the brain, and they say, hey, look, we're having really high blood pressure right now. We need to turn it down. And so the brain responds in kind and says, okay, well, I will now turn up the parasympathetic nervous system to try to counteract that high blood pressure, and I will try to turn down or inhibit the sympathetic nervous system. And the problem comes in because when the brain is sending these signals down the spinal cord to try to turn off the sympathetic nervous system, they can't travel past the lesion in the spinal cord. And so those signals never reach the area of the spinal cord where the sympathetic nervous system is being active right now. So then that massive sympathetic kind of outflow continues on until the noxious or until the painful stimulus is removed. And then that's what breaks the cycle. So that's the kind of basic overview of the mechanism or the steps of how AD develops in somebody with a spinal cord injury. Oops. So I think an easy way to try to remember, I shouldn't say easy, but a kind of a simplified way to try to remember the end result of AD is that above the level of injury, you're going to have parasympathetic activation and you're going to have sympathetic inhibition. But below the level of injury where the brain signals can't reach, you will have continued ongoing sympathetic activation. Okay? And we're going to kind of even dive a little bit deeper into these. So I had included these common signs and symptoms in a previous slide, but so just to clarify, symptoms refer to generally things that a patient themselves can feel or can notice. So things like a pounding headache, nasal congestion, anxiety, blurry or spotty vision, those are all things that a patient experiences. Those are referred to as symptoms. And then signs are generally things that are noticed or measured by an individual who is not the patient. So things like elevated blood pressure or hypertension, slow or fast heart rate, sweating, goosebumps, flushing, those are the common signs. And I should mention that some of these signs could also be considered symptoms. I mean, I don't think we have to get too caught up into which are signs and which are symptoms, but these are, I would say, among the more common signs and symptoms of AD. And we're going to kind of walk through why some individuals might experience some of these signs and symptoms and another individual may not, okay? So, as I mentioned earlier, these signs and symptoms can be very different from one individual to the next. And theoretically, your level of injury can influence which signs and symptoms you experience. People's bodies, I'm presenting, I would say, a very simplified version of this. People's bodies don't always follow the textbooks. You can have a mixture that doesn't quite make sense, but I think when we're trying to learn about this, it makes sense to try to kind of simplify and approach it that way. I think that's the best for learning. So one example I give here is that an individual who has a level of injury above T1, they may actually experience a fast or normal heart rate during their AD episodes, while somebody who has a lower level of injury at T4, T5, or T6, those individuals may experience actually a slow heart rate. And we're going to break that down here by looking at two different theoretical individuals who are experiencing AD. So the first person that we're going to look at is somebody who has a C5 AIS-A injury. Okay, and so before we kind of look deeper at this slide, let's just consider what is above the level of injury and what is below the level of injury. Okay, so this person's level is at C5. So like we talked about, the sympathetic system lives in the thoracic and lumbar part of the spinal cord. So all of that sympathetic system is below the level of injury in this case. So I think that's very important to note. So when this person experiences AD, again, we'll break it down and say this is what this red line represents where the lesion is, and above the lesion we're going to have the brain trying to turn on the parasympathetic nervous system and trying to turn off the sympathetic nervous system. So, with the parasympathetic nervous system turned on, that's going to have a tendency for the heart to slow the heart rate, okay? And then, as I mentioned, because in this case the entire sympathetic nervous system is below the level of injury, you're not going to be able to turn off the sympathetic nervous system at all. The entire sympathetic nervous system will be revved up or activated. And so that's what I'm referring to here below this red line. So that sympathetic activation will cause, at the heart, will tend to cause a fast heart rate, or what we call tachycardia. But in this case, the end result is a little bit up in the air because this person's heart is experiencing both parasympathetic activation and sympathetic activation at the same time. So they may have a normal heart rate, they may have a slightly fast heart rate. It's pretty hard to predict that. But we know that most of the vessels in the body will be constricted because the entire sympathetic nervous system is kind of revved up and activated. So that will cause the high blood pressure. That will also cause pale appearance of skin, because the blood vessels near the surface of the skin will clamp down and will cause a pale appearance in somebody. It will also cause diffuse goose flesh and sweating, because as I mentioned, the entire sympathetic nervous system is revved up. So that theoretically will cause goose flesh or goosebumps and sweating over the entire or most of the body. Okay. And let's contrast that with somebody who has a lower level of injury, who has let's say we're looking at somebody who has a T5 AIS-A or complete injury. So again, let's think about, in this individual, what lives above the level of injury and what lives below. So we know that the sympathetic outflow to the heart, as I mentioned before, generally is thought to live kind of T1 to T4, and that also supplies the sympathetic signals to most of the blood vessels in the upper body. So that section of the sympathetic nervous system is above the lesion in this case, and below the level of injury, you have the you have the mid thoracic cord, the lower thoracic cord, and the lumbar cord, and so you have part of the sympathetic nervous system that is living below the level of injury here. So in this individual above the level of injury, again, you'll have the parasympathetic activation, which will again have a tendency to slow the heart rate down, and then you'll also have sympathetic inhibition. So that sympathetic outflow to the heart in this case will be really ramped down or turned, inhibited. So again, turning down the sympathetic nervous system or the sympathetic signals that go to the heart will also cause bradycardia. So this individual may experience significant slow heart rate, or what we call bradycardia. In addition, because the brain is inhibiting the sympathetic nervous system here above the level of injury, you can get dilation of the vessels in the upper body, in the face, in the nose area, and this dilation of these vessels will cause flushing in the upper body or the face, will cause dilation of the vessels in the nose, which causes that feeling of nasal congestion, and the vessels in the brain will also dilate, and that is actually thought to be the source of this pounding headache that a lot of patients complain of when they get AD. And then again, below the level of injury, you still have this sympathetic activation, so that will be again what's driving your ongoing high blood pressure, and then this individual could have constriction of the blood vessels in the lower part of the body, causing paleness in the lower part of the body, and may also have goosebumps and sweating over the lower part of the body. Okay, so hopefully those two examples of these individuals with very different levels and how that AD may manifest in these individuals tells you a little bit about why people with different levels of injury can have a different constellation of signs and symptoms when they experience AD. Okay. Moving on to treatment of AD, again, there are a lot of helpful figures out there that kind of outline the process of treatment. But this one, this is looking a little bit small, so I apologize if it's not super easy to read, but I like the flow of this diagram. So, of course, the algorithm starts with detection of autonomic dysreflexia. So, if a patient with spinal cord injury is complaining of sweating or flushing or feeling like a sudden onset headache, you're clued in that this person may be experiencing AD, and that's when you should check the blood pressure and confirm that it is higher than that individual's baseline. And so the point that you then identify that AD is going on, right then your first step should be, if an individual is laying down, you want to have them sit up, and you want to try to loosen any type of loose clothing, remove kind of tight socks or leg straps or compression garments. And the reason we do this is that the thought is that raising your head will kind of work to reduce some of the high pressures in the brain, because that's really one of the areas that we're most concerned about. We want to reduce the pressure in the brain because sustained high pressure in the brain can cause this bleeding in the brain or the stroke in the brain, which we want to avoid obviously at all costs. And then once the individual is sat up and kind of tight clothing is removed, then you can start your search for the trigger. And as I mentioned before, you should always start with the bladder. So if somebody has an indwelling Foley catheter or a suprapubic tube, you want to check for patency. You want to see if that is draining properly or if there's a kink. that I would say is the most common trigger that I see on the spinal cord injury unit. And sometimes just if a lot of sediment is in the catheter, that can also clog the catheter and cause overdistension of the bladder. So you want to run through those checks. Oh, and I forgot to mention, so if somebody relies on intermittent catheterization, if they start experiencing AD, probably one of the first things they should do is catheterize themselves to make sure that their bladder is not overdistended. And in somebody who is voiding, urinating on their own, or what we call volitionally, it's always possible that that individual may have had a sudden increase in their prostate size that's now blocking their ability to urinate. So, it's a good idea to try for that individual to urinate and try to double void if they can, and if they feel they're really blocked up, if they have supplies to catheterize themselves, they should probably do that as well. The next, if there's no obvious trigger found in the urinary system, then the bowels is really the next place to look. And really you want to check, if you can, you want to do bowel care, or have somebody help you do bowel care at that point. I would say the use of lidocaine jelly would be ideal. If somebody has inflamed, hemorrhoids or has irritated mucosa around the rectum area, that could be triggering or driving AD, and so that lidocaine, which is a topical anesthetic, can help kind of calm that area down, and also it can make somebody less sensitive if you need to use something like a suppository or digital stimulation. The lidocaine jelly can help numb that area. But basically you want to check to see if there's kind of impacted stool in the rectum, or if there's a lot of stool, and if we can evacuate that, then that can sometimes relieve AD. And then, as we kind of went over the more common triggers of AD, so if that initial search for a trigger in the urinary and the GI system comes up empty, then you can start looking at other things like toenails or skin lesions, or see if there's any new swelling in the legs that could indicate a dislocation or a fracture. But really, I would say that after the search, if the search for bladder and bowel triggers if that doesn't turn up an obvious trigger, then you probably really need to start thinking about, well, how do I get this blood pressure down? It's the exact protocol is that if your blood pressure is above 150, you should start treating your blood pressure with medications like nitropaste or hydralazine to try to get that down. I would say realistically, I think you should focus on that search for a trigger in that first 5 minutes, and if you're not able to find an obvious trigger in that 5 minutes, then I think you can kind of shift to trying to get that blood pressure down. There are a variety of treatments that you can use to lower the blood pressure. Nifedipine is one medication that's used. Nitropaste, hydralazine, captopril, those are some of the more commonly used ones. In this region, at least at the VA, and as far as I know at the University of Washington and at Harborview, what we tend to use as our first line agent is nitropaste. So it's nitroglycerin and it's topical. You put it on a piece of paper or kind of wax type paper, and you can stick it on above your level of injury, and that causes absorption of the medication through the skin. We like it because it is fairly quick onset, and when you wipe it off, it's fairly quick offset, because you don't want a medication that's going to hang around for 8 hours, because once you find the trigger for AD and remove that trigger, then the tendency is for individuals to have go back to their baseline blood pressure, which in the case of a lot of spinal cord injury patients can be on the lower side. And so if you add an anti-blood pressure medication on top of that, then that can really drive the blood pressure down to unsafe levels. So, what we tend to educate patients to use is nitropaste, and for folks that we know have experienced AD, we send them home with a supply. We have the team give them instructions on how to use that safely. The next slide on this presentation is just a link to a YouTube video that reviews how to safely utilize or use the nitropaste, and So if for some folks that haven't reviewed that in a long time, that could be a good resource to look at. Now, what happens if you're going through this algorithm and you can't find a trigger, you're using the medications, but you really can't keep your blood pressure consistently at a safe level? That's really when you want to start thinking about kind of calling for additional help, calling 911 or EMS to take you to the hospital. It's very difficult to manage ongoing AD at home. Even if you have some helpers at home, at that point, I think it's wise to try to seek medical attention, medical care at the closest ED. Okay. So as I mentioned, this is the link, and this will be included on the resource handout. It's a useful link on how to apply that properly. Another useful thing that patients can carry with them that can help non-STI providers treat AD is something called an autonomic dysreflexia wallet card. There's a couple of different examples of these cards. This one that I pulled is from the PVA, or Paralyzed Veterans of America, and I think Christopher Reeve's foundation has a good example. And essentially they say pretty much the same thing. The front of the card explains in relatively simple terms what AD is, because there are going to be a lot of medical professionals that are not familiar with that term, and it outlines the common signs and symptoms, and then on the back is usually just a very basic outline or algorithm on how to start treating AD, and this I think can be helpful in cluing in providers that this is an actual phenomenon that could be happening with the patient, and could prompt them hopefully to reach out and ask a rehab physician or another specialty who's familiar with AD for help. Okay, now with that we're going to move on to orthostatic hypotension, which is another very common example of autonomic dysfunction. So OH is defined as a drop in 20 millimeters of mercury in your systolic blood pressure, which is that top number of your blood pressure, or a drop of 10 millimeters of mercury in the diastolic blood pressure, which is the lower number, within 2 to 5 minutes of sitting or standing up. And the symptoms generally include lightheadedness, dizziness. You can have blurry vision or kind of tunnel vision, like you feel like the room is closing in on you. You can feel generalized weakness. You may have some confusion, and if it is sustained, if your low blood pressure is sustained long enough, you can have loss of consciousness or fainting. I've also heard cold, clammy hands, nausea as some other common signs or symptoms that patients experience. Who is at risk for orthostatic hypotension? Really anybody with a spinal cord injury, at least initially, should be considered at risk for orthostatic hypotension. There have been a lot of studies looking at the prevalence of OH in our population, and one study reported that about 60% of patients with STI do experience this drop in blood pressure, but interestingly, only 25% of those individuals actually experience symptoms. But in general, orthostatic hypotension is more common in people who have tetraplegia, who have more complete spinal cord injury, or who have a traumatic spinal cord injury. And I will say, I didn't really include this in this slide, but in general, I have found that orthostatic hypotension tends to be much more severe in the acute period, so the first several weeks to couple months after you initially get your spinal cord injury, and then tends to be less of an issue further out, although there certainly are many individuals with spinal cord injury who continue to experience symptomatic orthostatic hypotension months to even years out. There's various theories on why that lessens, but in general, I think the thought is that somehow the brain adapts and is able to continue to function, either bring more blood in or continue to function with lower blood pressure, and it gets used to these episodes and continues to function normally after a period of time. Okay, so I think it's useful just to review the able-bodied response to a change in position before we get into the mechanism of how this happens in individuals with spinal cord injury. So when somebody goes from sitting to standing, that causes this increased gravity causes a fairly large shift in blood volume from the splanchnic bed down into the lower extremities. And so that drop in blood volume down to the legs will cause a reduction in your blood pressure. And that blood pressure is sensed by those same receptors that I talked about earlier that can sense high blood pressure. They can also sense low blood pressure. And so those receptors will then signal to the brain and say, hey, look, our blood pressure is low, let's try to raise it. And so the brain will do that by trying to activate the sympathetic nervous system and decrease the parasympathetic activation. So in an able-bodied individual, that will quickly result in constriction of the vessels throughout their body. It will cause an increase in the heart rate, and it will raise the blood pressure fairly quickly. Now, I'm sure you've heard that lots of patients without spinal cord injury do get these, when they stand up quickly, particularly if they're a little bit dehydrated, can get very dizzy and faint. But generally, it's self-limited. It resolves after a couple of seconds or 30 seconds at the most. But here, the response, of course, to this change in position after spinal cord injury is much different. So the same thing happens if an individual goes from laying down flat to sitting up or standing up. That causes a shift in your blood volume from the splanchnic bed down to the legs, and that again causes low blood pressure, and that's sensed by the baroreceptors, or those receptors in the aorta and the carotids, and the brain still tries to respond to that. But now the big difference is that depending on where your level of injury is, the brain cannot turn on the sympathetic nervous system, or if it can turn it on, it can't turn on the entirety of the sympathetic nervous system. So you're not getting this constriction of the vessels throughout the body, and the body is not able to successfully raise the blood pressure, and so the blood pressure, low blood pressure continues, and those symptoms can ensue and can last a longer period of time. Okay. There are various different treatments that we can use to combat this orthostatic hypotension. There's non-pharmacologic treatments and there's pharmacologic treatments. There's some, I looked at some recent review articles, and there is some evidence in the literature behind the non-pharmacologic treatment options that I've listed here. So functional electrical stimulation over the legs, compression of the abdomen and of the lower extremities, eating smaller and more frequent meals, and tensing arm muscles when somebody is changing positions. I will say that some of these interventions are more practical than others. I don't think functional electrical stimulation over the legs when you're changing positions is it's not going to be available to most individuals, so I don't think that's particularly practical. But certainly abdominal binders and wrapping the legs or wearing compression garments over the legs, those are things that certainly can be a nuisance, but I think are much more realistic for people to utilize. Before this talk, I hadn't really seen much evidence for the smaller, more frequent meals, so that was an interesting thing that I found this time when reviewing the literature. And I'm also not super familiar with the tensing of the arm muscles. It does make sense in that tightening of the muscles can help return some of that blood back to the heart. So it's interesting that they found some evidence that is effective at increasing blood pressure. And then from the medication side, there are a couple of different options. In reality, midodrine, the top of the list here, is the medication that we overwhelmingly use. That's kind of our first-line agent and our preferred agent. Fludrocortisone can have a lot of other side effects and can alter your electrolytes in the body. The nice thing about midodrine is that it, again, is fairly quick onset. It has a fairly short half-life, meaning that it doesn't stick around in your body for that long, so we're not seeing sustained periods of really high blood pressure. And ephedrine, that's a medication that we I think is contained in some decongestants, but we really don't use that medication these days that much. I've seen only 1 or 2 patients on it, and I believe it has more side effects than midodrine. So as a reminder, you always want to, if you haven't wrapped your legs before, it's something that you don't want to probably just jump into without some instructions. When you don't have great sensation over the legs, you want to make sure you're not cutting off circulation or making the wraps too tight as to cause a problem with your skin. So I did list a video here with instructions on how to properly wrap legs using ACE wraps. It is also something that you can ask a physical or occupational therapist, and they should be very familiar with how to do that. Okay, now moving on to this last example of autonomic dysfunction, so temperature dysregulation. In individuals without a spinal cord injury, they are able to maintain a fairly consistent core temperature even if they're exposed to hot temperatures or cold temperatures. And that is the autonomic nervous system, in particular the sympathetic nervous system plays a large role in that process. So when an individual is in a cold environment, the body will constrict the vessels that are close to the skin to minimize the heat that's lost through the skin, and they will also through the sympathetic nervous system, you'll start to shiver in certain muscles, and that's basically the body's best defense at generating heat from within to maintain that core temperature. And then in hot environments, are the ways that we keep our core temperature stable are by sweating, which when the sweat dries on the skin, that's an effective way to cool you down, and then to vasodilate the vessels that are close to the skin to allow more heat from the body to escape that way. So after spinal cord injury, and in particular after tetraplegia, there are individuals who really lose the ability to tightly regulate their core temperature. The term for that is partial poikilothermia, and essentially that means that their core body temperature can be influenced more easily by the outside temperature. So these patients are unable to vasoconstrict appropriately in cold temperatures and are unable to start shivering, so they are much more susceptible to getting hypothermia when it's cold outside. And in hot environments as well, they're unable to sweat appropriately and unable to vasodilate those vessels that are close to the skin. So this has been shown in laboratories to occur, and this is an old paper, but kind of a classic paper that looks at 2 groups of individuals here. So so on the x-axis you have the room temperature, and it's going up from 15 to 20, 25, 30, all the way up to 40. And then on the y-axis here you have the core temperature of the individuals. And so this dotted line here are people without a spinal cord injury, and you can see across the range all the way from like 15 degrees to 40 degrees, the core temperature stays in a pretty tight range here from just above, it looks like it's around 37.1 down to about 36.8 degrees Celsius. Now, it's not a perfect line here, but this solid line represents individuals with spinal cord injury, and you can tell here that although there is this kind of peak and valley, in general this line is sloped upwards. So as the temperature of the room rises, so does the core temperature of the individual. And so in this case, the average temperature in a room that's 40 degrees Celsius goes all the way up to about 37.4. It's not a huge change, but I would say it's significant. Okay? So what can we do to counteract this? We can, of course, just be cognizant of the outside temperature and try to avoid extremes in temperature. Obviously, you want to wear appropriate clothing for the temperature outside. You want to make sure that you're maintaining your fluid intake in in hot weather. I've been told the most effective, yeah, changing your fluid intake in an individual, particularly with bladder. Oh yes, of course. So he was just mentioning that.
How about quadriplegic?
Right,
Tetraplegic?
right. That so. It's not always the right answer to drink more fluids for somebody with a spinal cord injury in hot water, because this gentleman here was mentioning that he doesn't sweat, and so he's not losing the fluids through the body that somebody without a spinal cord injury would be. So that's an excellent point, and also by changing your fluid intake, you can also kind of change. If you're doing self-cath, you may kind of change the timing of that, and so in general, we want to be careful about making drastic changes to fluid intake in somebody who has a spinal cord injury. And so I was thinking about that as I was writing this.
I'm pointing. I take issue with that recommendation.
Okay,
for myself, with somebody that doesn't sweat.
That's absolutely fair. And so yeah, I would say that individuals with tetraplegia who don't sweat, I wouldn't necessarily follow this advice by increasing your fluid intake. The other thing, the other method which I still think would be effective in individuals who don't sweat is utilize kind of spray bottles with cool water, or even if it's not cool, basically trying to simulate sweating. You spray water on your skin, and if you have a little personal fan to then spray your skin after you spray the water on, that's an effective way to cool down. Now, we have explored these heating and cooling vests a little bit. I'm hard-pressed to remember any patient, though, that I've actually issued these to. They're a little bit, I think the heating vests are a little bit more popular in the multiple sclerosis population because their symptoms can get much worse in colder temperatures, I believe. I may be flip-flopping that. But of course, if you ever want to think about these options, I think it's really important that you talk to your rehab physician and talk to your therapist. There are risks that go along with these devices. If you are not sensate, you run the risk of having frostbite or getting burns with these vests. So they have to be, I think they have to have appropriate safety measures in place. But if you're really struggling with maintaining body temperature and you face a lot of exposure to extreme temperatures, this may be something you can talk to your doctor about. Okay, so moving on to the kind of last part, last phase of this presentation, I wanted to just talk about some newer and interesting areas of research. So we'll talk about ambulatory blood pressure monitoring, cognitive impairment after spinal cord injury, and the role of autonomic dysfunction in response to severe infection. So what is ambulatory blood pressure monitoring? I would be super curious if there was a live audience here, I would want to know how many people have even heard this term. It's something that is not new. It's been around for decades. But I would say it's not widely utilized. In particular, it's not widely utilized in the spinal cord injury population. So it's a method. So let's just think for a second about how we normally take our blood pressure. Most folks, maybe they have a cuff at home, and maybe they take their pressure when they wake up. But most folks, are taking their blood pressures when they see a doctor, or if they're inpatient or in the hospital. Even when they're in the hospital, generally, the most that folks are getting their blood pressure measured is like 3 times a day, maybe, at the very most 4 to 6 times a day. But obviously that is just a tiny window into what your blood pressure is doing throughout the rest of the day. So it's really, really incomplete, and in somebody who has large fluctuations in their blood pressure, it's nearly impossible to determine what your baseline blood pressure is just using those static numbers. So this ambulatory blood pressure monitor is usually a cuff that you're wearing, and then it's hooked up to a portable device that's either worn as a little sling bag, or it can be clipped to your belt, and it's taking blood pressure measurements at intervals that are usually pre-specified by your physician, every 5 minutes, every 15 minutes. But in any case, it's gonna paint a much more complete picture of what your blood pressure is doing and how it correlates to activity, because almost always these monitors are given with an activity journal, and I would say that if we're going to use it in our population, that's going to be a very important component of that, because we want to know, when is your bowel care, and what is your blood pressure during your bowel care, when are you transferring, when are you going to sleep, when are you cathing. So there would be certain activities that we would definitely want you to mark. And so who might benefit from doing this? I would say not every patient with spinal cord injury would derive benefit, but for those individuals who do notice that their blood pressure fluctuates greatly, or who know that they have frequent bouts of AD or get frequent bouts of lightheadedness or dizziness, I think it might be useful in kind of telling you why you're getting those symptoms. And so this is the tracings here on the right side I pulled from a paper that studied ambulatory blood pressure monitoring in the STI population. And so on the top, you see an individual without spinal cord injury. And so, this shaded area is when they're sleeping. Blood pressure tends to be lower and more stable when somebody is asleep. But then throughout the course of the day, you see these peaks and valleys. The top line is the systolic blood pressure, and the bottom line is the diastolic blood pressure. And of course, it's completely normal for blood pressure to vary based on activity, but in general, the body keeps it at a fairly tight range, and that's what you see in this upper panel here. The blood pressure is kind of hovering around 115. It looks like it's centered around like 115, 120-ish. Now, in contrast, look at the tracing in figure B here. So this is an individual with tetraplegia, and here we see that even during sleep, there is this large spike in blood pressure, and that corresponds, based on the journal that they were keeping, that corresponded to a kink in their catheter. And then you see these large spikes and large drops in blood pressure. They noted that they were doing their bowel routine at that time and then transferring to their chair at that time. And then you see some other peaks and valleys, and then there's another blood pressure over 160 here, which corresponded to a kink in their catheter. So this just really illustrates this wide variability that individuals with spinal cord can have in their blood pressure. So a very valid question and interesting question is, so let's say you are this individual in figure B. How do you determine what is your baseline blood pressure there? I think it's a very open question. I don't think there's necessarily an absolute right or wrong answer. In general, we think, at least from my perspective, I think of your baseline blood pressure as what is your blood pressure when you're just kind of quietly resting and not doing anything. So you can try to choose the blood pressures that correspond to that, with your activity journal. But another, I think, probably equally valid response might be, well, let me just take the average of all of these, and that will be my baseline. So I think there's different answers to that, and there's not a widely accepted, complete answer to that question. Okay, but so if this sounds interesting to you and you think you might benefit, the next question you might have is, well, how do I get this? So, it can be a little bit tricky. I know that we have ordered these devices at the VA and have received these devices, but we're in the process of trying to set up this program. We're running into issues trying to get the software that accompanies these devices to kind of integrate with our software at the VA. But outside, so I practice 100% in the VA system, which is, of course, a little bit different. We don't have to worry so much about the insurance, and that's one question that I don't know off the top of my head. Is this something that insurance companies are reimbursing for right now? I certainly think we can make a very good case for it, but I don't know the answer to that. Dr. Barnett just stepped out, but I'd be curious as to her take on that. In general, I found that the ambulatory blood pressure monitoring programs tend to run out of the renal program. So if this is something that you're interested in, you can certainly discuss it with your rehab physician or your primary care doctor and see if they think it's a reasonable thing, and see if the renal department at UW or Harborview does issue these devices, and hopefully at the VA we'll have this up and running within the next couple of months. I mean, another fair question is, okay, well, let's say I go ahead and undergo this ambulatory blood pressure monitoring, and I see this huge variation. What then? What do I do? And you know, the frustrating answer right now is that our treatment options are pretty limited. But I think it's very helpful in identifying what potentially are some triggers that are causing your blood pressure to spike, and you know, either trying to change those activities or avoid those activities. And you know, another I think a useful, so if you notice that your blood pressure is spiking and you're noticing you're having kind of lower abdominal spasms that you think are bladder spasms, and that's driving up your blood pressure, then, you know, for example, that could trigger you to look more into bladder Botox, which was actually I think there's building evidence that bladder Botox could be a fairly effective way for some folks to level out their blood pressure, because the bladder is so sensitive to hiking your blood pressure. If you are able to calm it down by, you know, essentially paralyzing it temporarily, then some folks have reported back that their blood pressure has become much more stable after they've received bladder Botox, but not everybody. We were talking about this, I think, before we started the presentation, but there's some emerging evidence that spinal cord stimulation could reduce blood pressure variability, but I would say that that is needs some more studies, and it's not in wide use now, but they are looking at transcutaneous stimulation, so meaning you can just put a device over your skin. It's not necessarily a device that you have to surgically implant. So, you know, I think it's interesting in that it's working towards, you know, possibly being more accessible to the you know, wider SCI population. We've looked at, I've been interested in some other medications that theoretically could kind of blunt this high blood pressure spikes, and you know, clonidine is a medication that I've thought about, but really there's not good evidence for that medication, and there is some concern that it could actually lower your blood pressure too much. So we are not routinely prescribing medications to try to level out people's blood pressure at this point. But you know, I will say that the research in this area, I think, is picking up steam, and hopefully it will produce, you know, a viable treatment option in the near future. Okay. So the next topic that I wanted to talk about, and that I think is very, very interesting, is this cognitive impairment in chronic spinal cord injury. So I think there's been more research in this area, and I think it's starting to be recognized that what we're seeing in the aging spinal cord injury population is cognitive impairment that is a little bit more pronounced than we would expect just based on that individual's age or their history of traumatic brain injury. And there, you know, in one study showed up to 60% of individuals with spinal cord injury suffer from some form of cognitive impairment. And I think there's been different theories on this. Medications is certainly an important thing to consider. You know, there's a lot of, after spinal cord injury, many folks are on, you know, decades of kind of sedating or slowing medications. Baclofen is a great example that, you know, tends to be a sedating type medication. Some folks will need long-term opioids. You know, I know that the medical community is trying to get away from that, but I still know plenty of patients that have been on long-term opioids, and you know, that's thought to possibly play a role in cognitive dysfunction or cognitive impairment. But you know, I think it's interesting that there are now, I think, some ties to this blood pressure variability and cognitive impairment. So let's get into that a little bit. So in an individual without spinal cord injury, the vessels in their brain have this ability to maintain a fairly consistent blood flow to the brain, even if the blood pressure drops or if it goes higher. In a certain window, it's able to maintain a consistent blood flow to the brain. It's called autoregulation. I won't get into, again, the super detailed portion of that, but it's a very important mechanism that keeps things as stable and as constant as possible with regards to our brain. So what researchers have shown in several different studies is that these large changes or fluctuations in blood pressure, it can put additional stress on the vessels, additional shear stress, which over time can cause scarring or what we call fibrosis of these vessels and basically cause stiffening of these vessels. And it's theorized that this stiffening of the vessels really impairs their ability to adapt to different environments or different blood pressures. So, if you've been experiencing these huge changes in blood pressure for a long time and now have vessels are a bit stiffer, it's thought that when your brain needs more blood flow, like if your blood pressure drops, the brain is no longer able to maintain this constant flow of blood into the brain. And another thing is that we have shown that when you're using your brain, if you're doing cognitive problem or tests, the areas of the brain that you're using, they receive more blood flow. It makes sense, and it's called neurovascular coupling. But there's some thought that if your vessels stiffen over time due to this blood pressure variability, you lose that ability as well. This ability, this neurovascular coupling ability. So I would say that it's still relatively new research, and I'm kind of eagerly following the literature to see what more comes out about that, because I think that's a very interesting link between this cardiovascular phenomenon that we see in spinal cord injury patients and the cognitive impairment that we can sometimes see after years of having a spinal cord injury. The question was, the number I cited, 60% of individuals with spinal cord injury have some form of cognitive impairment. The question was, what is that number in the able-bodied population? And it's a great question because we would need to compare that. But I don't know the exact number, but I can confidently say that it's considerably lower than 60%. If I had to guess or ballpark it, I would say 20%, 25%. That would be my guess. So as I mentioned, right now there's currently not a widely recognized therapy, either pharmacologic or non-pharmacologic, that can kind of reduce this blood pressure variability. But it is an active area of research, and one that I will certainly continue to follow and really hope that something productive comes out of this line of research. Okay, now the last topic that we'll talk about here is something that's kind of near and dear to my heart. It's a project that I've been working on for the last couple of years, and we are interested in looking at how patients with spinal cord injury respond to infection, in particular sepsis, which is a kind of widespread infection throughout the body. So we know that the autonomic nervous system plays a large and significant role in helping the body respond to infection. And so I think the reasoning was, or the rationale for looking at this line of questioning is that, as we've kind of explained through this presentation, individuals with spinal cord injury can have very different levels of autonomic dysfunction. There are some folks who may really have very little control over their autonomic nervous system, whereas some other individuals may have control over most of their autonomic nervous system. And we wanted to see, is there a difference in how these individuals respond to a severe infection? So what we did was we looked at the VA population, and we looked back over the years and found a group of patients, spinal cord injury patients, who had experienced sepsis. And so this was what we call a retrospective study. And we looked at those patients and we said, was there any difference in their vital signs as they were getting sick? Because we know that the autonomic nervous system is very important at determining what your vital signs are. And when I say vital signs, I'm referring to temperature, heart rate, blood pressure. And so we compared, we grouped the patients into patients with tetraplegia and patients with paraplegia, because the assumption there is that patients with tetraplegia will have more autonomic dysfunction than an individual with paraplegia. And we looked at if there were any significant differences in their vital signs. And what we found was that patients with tetraplegia were not able to mount as high of a fever as those patients with paraplegia, and also they weren't able to get their heart rate as high as individuals with paraplegia. And the reason that's important is that in the hospital, fever and heart rate are very important indicators that an infection is present. And so, if patients with tetraplegia aren't mounting as high of a fever or don't have as high of a heart rate, we could very plausibly be missing some cases of infection until a later stage when they get much sicker. And so that would be, of course, to the detriment of their health. So the objective would be, to try to start treatment for this severe infection at the earliest possible stage. And there's been a lot of evidence that shows that you get much better outcomes the earlier you start treatment. And sorry, this table that I included is a little bit busy and difficult to interpret, but essentially it's showing that, on average, patients with tetraplegia had lower temperature and lower heart rate, significantly lower than the patients with paraplegia. The other interesting thing that we found with this study was that patients with tetraplegia tended to have altered mental status or confusion much more frequently when they got infection compared to individuals with paraplegia. We don't have an exact reason why, but of course we have some theories, and they're tied to that the concept I was talking about a few minutes ago about kind of stiffness of the blood vessels. If their blood vessels can't react in the face of infection, then it's possible their brain is not seeing the blood flow that it needs, and they're experiencing confusion. I would say that this was definitely a smaller study. I think the total number of patients we enrolled was, or the total number of patients we reviewed and looked at was 35. So we are looking to do a bigger study and try to confirm these findings in a more robust population, with bigger numbers. So, and I think eventually our hope there is to change the parameters, because right now in the hospital we have set parameters that say if a patient hits these numbers, beware that they may be sick. And those numbers are based on the able-bodied population. And so by using those numbers, our fear and our concern is that we are missing severe or noticing infection late in a sub-portion of our population. So we're hoping to kind of validate these findings and change the parameters for certain patients with spinal cord injury, namely those with tetraplegia. Okay. So I think that pretty much wraps up all the topics that I wanted to discuss. Hopefully I'm on time. Okay. I don't think I'm too far out. But welcome any questions at this point.
Is if your baseline blood pressure is low, are you still at risk from autonomic dysreflexia? And is that why the definition is from baseline?
Yes, that's a great question. So the answer to that is absolutely. Even if your baseline blood pressure is low, you are still absolutely susceptible to experiencing autonomic dysreflexia. And yes, that is exactly the reason why we say know your baseline, because really we consider 80 to start when it's 20 points above your baseline. So if your baseline is 90 over 50, which is not, I mean, I've definitely seen that low of a blood pressure in somebody with tetraplegia. That means you could have, AD at 111 over 71, which most people would consider a very normal blood pressure, but in your case, that would indicate that you're experiencing AD.
You had mentioned that orthostatic hypotension might become better regulated over time. Can you speak to the longer-term prognosis for AD? Does that tend to become better regulated, or is that different?
Great question. And again, I can't think of any literature off the top of my head that I can cite, but from my personal experience, unfortunately, I have found that that does not seem to improve. The frequency of AD does not seem to improve with the chronicity of the injury. So, for reasons that I don't quite know, it seems that if you are susceptible to having autonomic dysreflexia, you are kind of always susceptible to having autonomic dysreflexia.
Does aerobic exercise for a person with SCI help to limit cognitive impairment, or any knowledge about that?
I unfortunately don't have any direct knowledge of that. You know, I think that there are very few downsides to regular exercise, and so I would not be surprised at all if we found a benefit in terms of cognitive functioning. But you know, I can't say that with certainty. So I think that's a very good question, and I'll try to look at some of the more recent literature to see if there's an answer in there. But regardless of what my answer is, I think you should still exercise.
Yeah, I'm not sure if there's evidence in the able-bodied population either. I mean,
Right.
there might be some, but
Yeah.
we're not sure.
Yeah.
A follow-up question to that was, can people with SCI actually get aerobic exercise? Is that possible?
Yes, great question. So that is a real issue. Getting aerobic exercise and elevating that heart rate it can be very difficult in patients with higher levels of tetraplegia, because that really relies on the sympathetic nervous system to try to ramp up that heart rate. And we have there are studies out there that show that heart rate response to exercise is blunted after spinal cord injury. So and what's more is that it can be difficult. I think they've used things like functional electrical stimulation in the lower extremities for individuals that don't have motor control in their legs. And I'm trying to remember, I mean, I don't think that's as good at raising the heart rate as kind of native exercise, but I know that an arm ergometer certainly is at least partially effective at raising the heart rate and getting aerobic exercise. But yeah, I mean, certainly it is. I would say it is possible to ramp up your cardiovascular activity, but it is much harder if you have tetraplegia.
All right. Lots of questions, so we'll see if we can take a few more.
Okay.
If you have a very incomplete cervical spinal cord injury, are you less likely to experience the medical issues discussed today?
Yes, I would say in general you are. But the interesting thing that we have noticed, and there are papers written on this, is that while in general I do think there is a correlation between the severity of the sensory and the motor findings from spinal cord injury and the amount of autonomic dysfunction, you do see cases where, for whatever reason, it's bad luck that somebody catches more autonomic fibers in their spinal cord injury, but they could have relatively mild motor deficits and sensory deficits, but have much more dysfunctional autonomic function. So there are definitely exceptions like that. But I would say, in general, yes, if you have a more incomplete injury, you are less likely to experience some of the things that we're talking about.
Mentioned that the percentage of SCI patients who have a cognitive impairment is probably about 60%. Any idea on the severity of that, or is it pretty variable?
I think it's quite variable. I think there are domains of cognitive impairment that you tend to see more frequently. I want to say short-term memory is something that I think they've noticed can be particularly affected, but I'd have to have some more resources in front of me to get into the specifics about the domains. But yeah, I think there is a wide level of variation in the degree of cognitive impairment after spinal cord injury.
If you can't do the ambulatory blood pressure monitoring, but you have a cuff at home, is there any advice on taking it throughout the day to kind of come up with a baseline?
Yeah, I would say that is that's a great question. So the first advice that I have for people is to choose a consistent time of day to measure your first blood pressure. And what we generally recommend is that after you wake up, give yourself a few minutes to kind of get fully awake, and then check your blood pressure at that point. And I think it makes sense if you're particularly interested in certain times of day, and that could correspond to symptoms. I noticed that a fairly common complaint after spinal cord injury is really feeling fatigued after meal time. So if you're, I would say it's very it would be useful to take your blood pressure before you start eating a meal, and then when you're feeling tired after, you know, the meal, to take it again, because then you can establish a pattern. And you should do that for several days to try to establish a pattern, but then you can actually bring in some evidence and say, well, yeah, I'm feeling tired after I eat, and look, my blood pressure is falling, you know, 10 points after I eat, and that very well could be explaining some of the fatigue, and you know, so that can lead to actually specific interventions in that case as well. I do know some patients that take midodrine before they eat a meal, and that helps fight off a little bit of the post-meal fatigue. So yeah, I think that's an example of how you could try to take blood pressure at different points of the day to come up with something, a useful pattern that can be treated by your medical team.
So thank you all very much for attending, and thank you, Dr. Song, for your presentation. I think that was very informative for everyone, and hope everybody enjoyed.
It was my pleasure. It was my pleasure.